First off, thank you all for coming here tonight. And yes, we do have a spiel on this Public Insight Network. It's super important. You may not hear from us for months, years, but I swear we actually go through this once in a while and go, oh, look at this person. They have expertise on this. Let's give them a call. But I do want to thank you all here for coming tonight. I mean, this is something that many people within the newsroom talk about, transgender issues. There's a lot of questions that our own staffers have. In some ways, I feel like the reason they come to me is just because I'm that one person who says, oh yeah, I have a friend who is, but that's not real expertise. And that's why we wanted to bring people who have been living these lives and dealing with transgender issues to tell us a little bit more about their experience, and also you. So just be aware that if you have a story to share, if you have something to say, don't be afraid to share it. We have our staff members with microphones back there, and I believe if you have something to add or have questions about, we'll turn it over to the audience at some point, and I believe the deal is just like walk over to the side, and one of our staffers will approach you with the mic, and you can ask your question. So let me get a little more into about why we're talking about this now. I mean, in some ways it's been framed as this transgender moment. You can hear it as talked about as this growing awareness, or there's this tipping point. For transgender people, this has actually been going on for decades. This is not something that's very new, just within the past year. But for people who are outsiders, not within the LGBT community, this is kind of new to them. And a lot of it was sparked by this moment.
Are you a woman?
Yes, for all intents and purposes, I am a woman.
And of course, that's a former Olympian who graced Wheaties boxes. Bruce Jenner announced that she is transitioning, gracing headlines around the world. She joins a lot of famous trans people. There are different ages, different backgrounds, different experiences. But the thing is, we're here because not everyone who's trans is famous. Not everyone has the resources that they have. And we wanted to understand what it's like being trans in Los Angeles specifically. What are some of the issues they deal with? Where do they go? And one of the easiest way for us to understand that is just something very basic to all of us, healthcare. And the phrase that trans people might hear once in a while when they go to a medical office. The doctor won't see you now. And the thing is, what does that actually mean? What does that mean when they go to a doctor's office? That actually just means that 19% of people, transgender people, have been denied treatment by doctors in some way or another. We'll understand a little bit more about what that means tonight, but I want to introduce you to our panel. First off, to my left is Tisha Baird. Tisha Baird, I was gonna say Trisha. Tisha Baird, she is a doctor over at Kaiser. She's the lead endocrinologist for transgender care. She's also the inter-regional LGBTI committee member, so I have to read this off the card since I can't read that off the screen. Next to her, Alexander Fuller. Do you prefer Alex or Alexander?
Alex.
Okay. Alex, member of the trans men fraternity Alpha Omega Nu. We'll get to learn more about this fraternity, which is super fascinating to me. And also the Brown Boy Project. He's also the co-founder of Kingsmen Court. And then on the far side, way far away from me, is Aydin Olsen Kennedy. We haven't updated this, but got married, has a new hyphenated last name. An associate clinical social worker and a former director of the Trans Health Program at St. John's Clinic in South LA. So thank you all for being here tonight.
Thanks for having us.
Thank you.
Absolutely.
The first thing I actually really want to do is not talk to any of you right away. That Public Insight Network thing you heard about, I was going through some of the people that we've talked to in the past, and through a roundabout way, I found a transgender person who shared this really incredible story with me about a time that she tried to get medical care. I'm not going to spoil it, and just so you know, it's a long story. It goes even longer, but we don't have all night to hear it, even though it's a great story. But I want you to meet, or she's not here, Michelle and Cherie Evans. Michelle on the left, a transgender woman, lives in Orange County. And again, she told me this story about one time when she had to go to the emergency room for a problem with her broken legs. If this will play.
Within 8 hours, I had 2 separate accidents that left me with 2 broken legs. Not a good day at all. And so they put me into the hospital. They scheduled surgery for the next day. I had to have both legs basically rebuilt. So I'm now a bionic woman. I have things stuck in my legs to hold me together and such. And after about a week in the hospital, they figured there wasn't much else they could do in the hospital, so they transferred me to a nursing home. Basically, all the nursing homes said, we're not going to take her. We do not want a trans person in our facility. Our medical plan finally got somebody to take me. As a trans person, as a trans woman, so I have to be on an estrogen supplement for the rest of my life. And almost immediately, I had a doctor assigned to my case. And one of the very first things that she told me was, you're never going back to estrogen. You shouldn't have been on estrogen in the first place. That's just wrong. What they allowed you to do was wrong.
That's Michelle Evans' story. Again, it goes on much longer than that. But it just sort of gave me a taste for something I've never personally experienced before. Aydin, I want to start off with you. As somebody who's worked with many trans people in a facility, does that sound familiar to you?
Oh, absolutely. People's, at St. John's, we had numerous patients who had come to us having tried to access care at other locations, usually through private practitioners, not necessarily through like a specified or designated clinic. But the first thing they'd be met with, and so there's a hand motion that often goes with it. It's sort of the hands up. Oh, we don't treat you. We don't treat that here. So that's where that first. So it's a verbal denial, but it's also a visual representation of not being accepted. But there's a lot of times that providers will unfortunately allow their own personal bias to enter into that medical relationship when it really has no place there whatsoever. Gender and gender identity and being trans is one of the few places that I think people still feel somehow justified and comfortable inserting their personal belief system into that medical relationship. And it's grossly inappropriate across the board. If we took gender out, would we ever allow a medical provider to insert a personal opinion? Probably not. There'd probably be consequences or repercussions if there were, but unfortunately, situations such as this that Michelle experienced, it's all too common, unfortunately.
And by the way, when we're talking about doctor's offices here, we're not talking doctor's offices just specifically related to trans care. This is just across the board. No matter or it doesn't matter in some cases whether you're trans or not. You're just there for, I don't know, you name it.
Yeah.
Alex, I want to turn this over to you. I mean, what, as a trans person, do you think, are you looking for something that's different, or that's special, that you want people to be more sensitive than what other people would ask for from their doctors?
We're looking for the same, well, for me personally, I'm looking for the same respect that you would give any other patient. As far as anything different or new or changed, it would be the pronouns. If your name is not changed legally, then I would look for someone to say, hey, what is your preferred name? But as far as actually the quality of care, I would expect the same as the other patients. I'm human just like everyone else.
Mm-hmm. We'll get into a little bit of those details like the pronoun in just a little bit. Dr. Baird, I mean, you work with trans people. You don't identify as trans yourself, but this is a learning process you actually had to go through and one that you teach other people. You told me a story a little bit about how you learned this in the first place, some mistakes you made.
Right.
But tell us more about that.
We kind of talked about this, but when I went to medical school not that long ago, we had one page for LGBT care, all 4 years of medical school. That was my whole training and experience. So when I was training at LA County, we had a patient that was in the jail ward who had tried to self-harm. And I never really understood. I didn't really understand what transgender meant. I didn't know what trans male, trans female meant. She felt like she couldn't stand having her genital anymore, and she tried to remove it. And I didn't know what to say. Mm-hmm. I didn't understand it. I didn't know how to say pronouns. Nobody had ever said, even what do you say? What do you ask this person? Granted, I could care for her medically, but, the jail was refusing to give hormones. They had refused surgical options. So it was her basically telling me, you need to figure this out. You should know this. As a healthcare provider, you should know how to talk to me. You should know what to ask. And I really should have. Somebody should have told me.
What did you do? Just have to Google it? I mean,
Yeah,
you just like
and
made so many
it's
mistakes
the-
and you said, oh,
It
did I do
was
this
the
wrong?
jail ward, so we don't have Google up in the jail ward. So I actually got on my phone and stood in the hallway outside the jail ward, and I started searching and tried to figure out what can I do for this person besides trying to help for their injury. What am I doing? What can I help? And how do I talk to this lady who clearly had some, severe stressors being incarcerated, and how do I do that right?
Mm-hmm. What were the most simple rules that you discovered? Like, oh, I had no idea. That's it?
I think the thing that when we go out and talk to everybody, it's literally if whoever is presenting in front of you, and if you're confused, you're just asking, what is your preferred name? I mean, just like Alex said, what do you prefer to be called? I mean, and if I misgender somebody or accidentally use the wrong name or something happens, saying I'm sorry, recognize the mistake, and then move forward. I think that's what everybody wants.
Let's talk a little bit more about how you're taking what you've learned into the rest of Kaiser.
Mm-hmm.
One of the things when we actually met in your offices, one of the things that first caught my eye, which I thought, oh, that's funny, was just the bathroom.
Our bathrooms.
Which it's one of those very simple things.
Of course.
I noticed it here. There's a men's bathroom. I don't think there's a women's bathroom. I wasn't too sure. I didn't see it.
Yeah.
But let's talk first about that. Why the bathrooms? I know it's probably obvious, but be nice if you say it and explain it. Like, what was important to patients?
Well, I mean, why can't there just be a bathroom? Why does there have to be a male or female or, even a gender-neutral bathroom, as this is called? Why can't it just be a bathroom? But it's because if, you have a multi-stalls and you walk in and you identify as to somebody else on the outside, you look a little male and you walk into the female bathroom and then people get upset. And so, we're just trying to make everybody comfortable. This is the bathroom. Everybody has access to it. That's basic healthcare.
And let's talk about what you tell doctors, nurses, other medical professionals, because I love this slide.
The Genderbread Person?
Okay.
Is that what this is?
So you got to explain this. What is this?
So, I know this is a little cartoonish, and we're not trying to be offensive, but, when we're talking to anybody what we call front-facing staff, so that's anybody who you would meet, a clerk, a radiology tech, a doctor, somebody cleaning up the trash in our facilities, they need to understand, not only tolerance, but sometimes how do you look at somebody? Because when you use the word gender identity and transgender and transsexual, people don't understand the terms because, like me, they didn't get this in, school. Maybe nobody talked about. Maybe they don't know any transgender patients or friends. So just a starting point. What is gender? What's the difference between gender identity? What's the, it kind of goes about that there's a spectrum, which is not always recognized by everybody. It's not just a binary system for all of the people that we see. And it could be somebody in transition. It'd be somebody who doesn't identify as necessarily male or female, who identify maybe as both or agender. So it's just a way for us to kind of get the talking started. Everybody laughed when it came up, but it's to try to make everybody comfortable,
If you had something that was much more straightforward, didn't have the genderbread thing.
Right. The PowerPoint
would it have-
presentation that
Would it be-
we're all infamous for.
Would it just be as effective?
It's
Would it be not?
words. I mean, I think everybody has probably sat through a PowerPoint presentation where there's a whole bunch of definitions, and you're in that class or that lecture or that educational thing, and you're like, blah blah blah, blah blah blah, definition. This is just trying to make it, can everybody remember the Genderbread Person, and make it more accessible for everyone out there, no matter what your comfort and education level is.
Aydin, in terms of clinics and places that people can go to for care that thinks about not necessarily these terms, but are sensitive to issues, how many are there in a place like Southern California, first off?
I think that first understanding what are we talking about as far as the clinic is concerned. There's a lot of medical providers in private practice who maybe has a trans patient here or a couple there. Since of like organized and identifiable and participating in community awareness and so forth, and actively training their staff and faculty and so forth. There's certainly Kaiser's program. There is the Transgender Health Program at St. John's Well Child and Family Center. There's the clinic that's housed here, well, not probably here at this stage, but at the LGBT Center here. And then there's Children's Hospital that provides care to youth up to the age of 25, and then they transition to one of the adult provider clinics. So, when I first came to LA a couple of years ago and started working at St. John's, I was under the impression, I think a lot of people are like, this is Los Angeles. There's probably a plethora of services. And the reality is that there's not, and that the programs that exist right now are having a hard time keeping up with the demand. There tends to be wait lists.
And to put this in perspective, by the way, you started with the program in January 2014. You told me you had 9 patients.
9
to start
patients.
with, and when you left recently, how many did you have?
Just under 450.
So.
Yeah. So that's a little bit of growth in a short amount of time. And and I just spoke to the current the interim coordinator and sort of getting a pulse on things, and there's no slowdown, and there's no reason to think that anything is going to slow down. And I know that the program at the LGBT Center here also sees a lot of patients, and so the need is vast and it's big. And but it also, I really appreciate Alex's comment about, I want just care. But I think what is important to acknowledge, and I'll sort of be the one to acknowledge it, is that as a trans person, as a community, we've come to really lower the bar of expectations for care for ourselves. Because we are met with, oh, no, we don't treat you here. And so we are overjoyed when someone just doesn't turn us away. Mm-hmm. And so I think that we need to be having an honest conversation of saying, that sounds nice, like, oh, treat me like everyone else, but we're not like everyone else. And so I think that it's really fair and appropriate for us to say, I'm not like everyone else because I'm not cisgender, and so there are some specific things that I'm gonna need, and if you can't do that, then I think as a community, what you owe us is to be honest about that and say, I can't or will not do that, but I will connect you to somebody who will do that. And I think that that's where the gap happens. If you're unwilling to provide the care for whatever reason it is, personally I think you're doing harm, but if you elect to not do the care, then in any other situation, if you had a patient who needed something that was outside the scope of your practice, my assumption would that you would engage to some degree in making sure that person got connected medically to somebody who would provide that care. And that doesn't happen, and we need to be more critical about that.
I also want to talk about affordability because, medical care is not cheap for anyone. In Caitlyn Jenner's interview with Diane Sawyer, one of the things that she did, to be quite fair to her, is that she checked her privilege and that she kind of admitted she's going to have it easier than most people. Mm-hmm. I'm just going to play this for you, if it'll actually play.
Jenner says he knows how fortunate he is to have money from that reality show and his new documentary series on E!, which airs this summer. It also means he has money for good medical care during his transition, cosmetic surgery first.
You do face, breasts, all that kind of stuff.
But the unfortunate thing is that most trans people are not like her. Here's some startling statistics, not to get too overwhelming with PowerPoint. First off is that 90% of trans people say they face some type of discrimination in the workplace or in terms of employment. Another startling stat is that, what does that mean? Well, historically, and still today, from what I've heard from some trans people, is that, they have to turn to the black market, where 1 in 6 will engage in sex work, drug sales, other underground work. This is the reality I have to deal with. I wanted to understand more about what it's like to just try to find a job, just any kind of job as a trans person. Alex, you're self-employed right now, and what is it like for you? Where does the conversation start? When you're applying for a job, what are you thinking about? How your status comes into this?
For one, my resume is an interesting situation to navigate because under my previous name, I have tons of experience, tons of it. I have plenty of employers that have seen me through years and years of different types of jobs that I've done, but now Alex has no experience on a resume. And so I'm learning now how to navigate that particular situation, and I've come into a couple of situations where I've gone to a job interview and I've gotten the job, and then 2 weeks later, my background check will come back, and then they tell me I've lied to them because I didn't disclose that my name has been changed. So that's a lot of different barriers. Just a lot of times you go to job interviews and you don't know whether, well, should I disclose or should I not disclose? Should I let them know that my name has been changed? Because you've gone through different experiences where, okay, I've gotten fired because my name was changed here, and then maybe there are a lot of instances where the gender marker on my social security card did not match up with the gender marker that's on my ID. So I had to go back through Social Security and make sure that the gender marker was changed, because when it comes back as a ding.
This is a lot of steps, by the way. Like, if you're putting in a resume, you're not just thinking, okay, do I have a reference on there? All the dates are checked. You're calling back and saying, like, hey, I need this change, I need this change, I need that change.
Right.
That's probably, like, what, months or years in the making?
Well, it depends on whether you can call back and talk to that employer and say, hey, look, you remember me? I worked for you back in '95. But
My voice was probably a little bit different.
right. But my name has been changed. But I'm going to have somebody call and, I was a reference. This was me then. This is me now. So not only is that a conversation that you kind of really don't want to have, because you don't know how they're going to respond on the other end. Mm-hmm. So you're like, well, depending on what their response is, you have to gauge whether you want to actually put them down as a reference or not.
So what does that mean for you when it comes to affording health care, having insurance, getting coverage?
Well, right now it's Medi-Cal. And right now I can afford Medi-Cal. And, I just go with the healthcare coverage through that. But as far as being able to afford private care, that's a no-go right now.
Aydin, you've just heard that. I mean, does that jibe with some of your experience or what you've heard from other people as well?
My personal experience?
Sure.
Well, no, I'm a white guy. My world is very, very different. I'm a white trans man who can walk in the world and be completely not disclosed. No one knows that I'm trans unless I tell them. So, I don't face a myriad of the things that certainly folks of color, trans women face. And so I've had really zero issues and zero barriers, and so I think that when we talk about privilege, like, we have to check our privilege. We have to, I appreciate that Caitlin did that, and I think that I certainly take that very, very seriously. Have I had difficulties navigating systems? No, I'm white. Systems are made for me. So do I hear Have I listened to Alex or versions of Alex, or in my current position at the Los Angeles Gender Center, when I was at St. John's? Absolutely. There's such a common theme and such a common thread about access, poor access, no access. To go through the entire process to change your name and your gender marker now is much easier than it's ever been historically. But when I went through this process, even as a white guy, insurance didn't cover my surgery. I had to come up with that money out of pocket. I had to figure out how to do that. Mm-hmm. I had to pay for numerous letters to get hormones, to get surgery, and then do the gender marker and get driver's license, and and so it's a tedious process, and it requires that you have financial resources, and it also requires that you have resources that too often, if you are on the receiving end of a lot of discrimination and a lot of oppression, sometimes you just don't have those resources. And so I think it's important that we think about that as well.
By the way, I want to get back to the point about being trans men, which, it's a lot of my personal experience. It's mostly, I'm more familiar with trans women, trans men. I was really fascinated by both your stories. And one thing that I took away from in talking with many people who are trans men said they all agree. They basically say, yeah, we have a lot of privilege, we can pass. I think one actually went as far as to say that I identified as LGBT, but once I transitioned into a trans man, I just kind of checked out of the community. I didn't really identify as much anymore. Tell us a little bit more about that. What does this mean as a trans man, and when you see what trans women actually have to go through? What do you take away? What do you say?
I don't know. I'm kind of in an interesting situation because in, I guess, the metro world, going to school or going to work or being in those type of environments, I can kind of seamlessly move and navigate through those particular environments. But in the environment that I live in, being that it's a little more urban,
You're in South LA.
right. So being in a little more urban area, they've watched me transition. So they've seen me go from almost male to all the way male. But once I transitioned, I got challenged quite a bit. So they wanted to see how manly I really was. They wanted to see how much of a man I really was. So, I've been through quite a few fights. I've been through quite a few situations where I was challenged to see how much of a man they could get out of me. So I'm kind of in the situation. It depends on the environment for me.
By the way, I just want to be clear. I mean, you told me that they challenged you. You won.
Yeah.
You took them to the gun show.
Quite a few times.
Just to be clear. So, I mean, we'll talk more about this. I'm interested to hear what people in the audience might have to say or more questions just in general. I also wanted to talk about when you are discriminated against, for example, in the employer situation or in the healthcare context, what happens? Well, first off, in California, it is illegal to discriminate against an employee or an applicant, a job applicant, just because of their identity. Several states do it, not all, several. I did have a chance to talk with Sasha Bookert from the Transgender Law Center. They are based up in San Francisco. And one of the things I've learned is that, yes, if you are discriminated against, you can challenge it. It's just a really, really tough process.
There are a number of remedies. One thing might be to contact Transgender Law Center, or you could contact a private attorney, or you could file a complaint with the Department of Managed Healthcare, which is the state agency that oversees healthcare.
But the thing is, it's a lot to go through in order to bring a challenge against a prospective or current employer or a healthcare facility. First off, Aydin, I mean, you've dealt with people who've had some issues in the past before. I mean, how would you coach somebody if you're helping them to be an advocate, if you're their advocate, what do you tell them?
I think I appreciate the question. It's a tricky question, to be honest with you. For me, I navigate these two spaces of being a trans person and also being a social worker and an advocate and activist and an educator. And I think that when I've sat across the table from somebody who has just experienced something, probably not for the first time, probably have experienced something similar to it over and over, but they're talking to me, I have to be very clear about what role am I going to take at that time. I think that the idea of suing, that's nice and it sounds really great, and the headlines for that person who successfully went through the lawsuit and won a lot of money, I think that it's a pipe dream for a lot of people. When you are on the receiving end of discrimination, I think that having clarity about the entire process is going to be a whole slew of people. Their entire objective is to prove that you're lying. And that's a really exhausting, tedious process when you sort of think about what that means. So, I more often than not, for me, I hold space for people, and I really listen to what's happening for them and validate that, and figure out, well, what are the resources that I can help them get connected to meet their needs? Because if they've been discriminated against, they have an unmet need. So figuring out how you still have an unmet need, so how do we meet that need while we're also sort of figuring out the other thing. But from a community place, I think that when we as a community stop, when we start celebrating ourselves, not accepting and not tolerating, but when we really start celebrating ourselves and celebrating what it means to be trans, and then expecting people around us to celebrate, I think that we bring something different to the table, and that's a really important piece to think about. So for folks who want to pursue legal action or some sort of recourse, I think the best thing that I have done in the past is figure out how do I create an army of people around you. So that you're not there by yourself, because it's an incredibly lonely experience. So if I can gather a community of people to stand in solidarity with you, behind you if you start to fall a little bit, ahead of you if you need to be led a little bit, but mostly shoulder by shoulder, then I think that's the greatest thing that I can do.
Dr. Baird, let's take this to the healthcare world. When people are looking for a doctor, I mean, obviously they don't want a doctor who will challenge their identity.
Sure.
Do you have any advice for them if they're just calling around for doctors for I don't know what, for whatever reason? I don't know. Is there a strategy you would say that say up front, I am transgender, Are you cool with that? I don't even and that, which is also just not maybe appropriate. But
Right.
what advice would you have for transgender people who are just looking for doctors who are just sensitive to it?
I think, it's something that I can only speak at what happened at what we've done at Kaiser. So if you call just the general appointment line, you can specifically ask for someone who has had training in LGBT care. And that includes mental health workers, that includes endocrinologists, primary care doctors, there's OB-GYN, there's other surgeons. So our goal was that, as Aydin said earlier, there are sometimes some extra things that you need to be aware of if you're taking care of somebody who's starting hormones or transitioning or needs surgery or is post-op care. And so, as I'm taking everybody as they come in, but there still needs to be things that we're monitoring, and there still needs to be people who understand what it means to take care of somebody who needs hormones, who needs surgery, who may not be doing well or not well at work, and who need social work help or who need mental health care. And so we specifically created multiple training programs so that there was there's a list of people who are interested, who have signed up, who've done the trainings, that if you call into just our call center to set up an appointment, you can ask. Outside, I think that there's different websites that will, talk about people who are trans friendly that they've seen as surgeons or as physicians. There's websites. Oftentimes they get, sent to the Gay and Lesbian Center to say, do you know community people? And then word of mouth is pretty big in the trans community, and trying to find out somebody who, if you had a really good experience with somebody who knew what they're talking about, I think that's how a lot of people find good physicians.
And when we're talking about the network here, one thing I remember, I was doing a story on the Pasadena Pride Center, and I was there during their listening session about, okay, here's what people in the community want. One person talked, he identified as bisexual, and he just said, I'm way out here in San Gabriel Valley. It's easy for me to probably find a doctor who is sensitive to these issues in Los Angeles,
Right.
but I don't want to drive all that way. So if I want to find a doctor who's thinking about these things over in this area, the San Gabriel Valley, not so many options. So we're talking here in Los Angeles, but if we're going outside of this bubble of ours, like what resources would you suggest? Is this just more like just looking online forums and Yelp, or I don't know?
I think that's some of it. Again, I can speak to Kaiser. We, for every single area in Southern California, we have people who are trained. So it doesn't matter if you're at Riverside or you're in San Diego or you're in Kern County or in LA, there's somebody. But I think outside of that, it gets more difficult when you have a private insurance, and maybe you have access to somebody like Aydin, maybe you don't. I think it's searching on the internet, it's forums, it's asking other people in the community, the local Gay and Lesbian Center or LGBT Center. Sometimes people call me and they'll say, I need to have, I'm losing Kaiser insurance, or I'm moving jobs, or I'm going to somebody in private practice. Do you have names? And that's what I'm doing. I'm on Google saying, is there anybody locally in Riverside who I can, give somebody a good refer group, like say, hey, this is what I found at UC Riverside. They have a good, support group that you need. It's difficult. I think it's very disjointed, and I think that's part of the frustration, that there's probably practitioners out there, but there's no great way to identify all of them.
Mm-hmm. Actually, Alex and Aydin, as trans people yourself, how did you find the doctors that you were looking for?
For me, I like she said, it's a lot of word of mouth. I found Aydin and St. John's through Trans Pride. They had a booth over at Trans Pride, and I was like, whoa, doctor. Beelined it, so it's a lot of word of mouth. Like, you get on these support groups through Facebook or social media or whatnot, and you just start asking around, like, hey, who's a good doctor? Who's in your area? You talk to people that are in your spaces.
Aydin?
I would agree with Alex that at St. John's, the majority of our patients come from word of mouth, friends, social media, and we do get referrals from other organizations and agencies for sure. But don't Yelp. Looking for, I'm going to say no to that. But I do think
John,
that,
I won't
anymore. Right. We love Yelp, but there has to be some limitations. So, I think that, and I just, I'm a little stuck, so I have to go back to just sort of imagining what it would be like if to call and say, hey, I'm me, and are you okay with that? Like that, there's a certain amount of like psychological trauma that happens just as a result of like that. Right? And that's actually an incredibly difficult thing to ask, because that means that you are just you're opening yourself up for no, right? And so that takes us back to that sort of that breadcrumb lowering the bar is that sometimes what we do is we don't actually care if you're a good doctor, we care if you give us what we need. And we have to have some clarity about how we're defining good. If good is about getting me what you need, and is that good enough? But in LA, there are, I think Google is, I think Facebook, Twitter, a variety of social media, asking community, and then looking at who's at LA Pride, who's at Trans Pride, who are at these different places, and being able to call into resources of calling Kaiser. And if somebody doesn't have Kaiser insurance, then you have a whole network of people who probably are willing to take a couple of minutes and figure out, like, I don't know, but I could probably help you find somebody who does know. And so making sure that you're also thinking, like, look outside of maybe what's the obvious.
By the way, you mentioned the breadcrumbs there. There's
Yeah.
a story that you told me about the waiting room at St. John's. I think the story of this one trans woman, I believe, who, well, you tell the story, and it just really got my attention when it comes to, like, identifying this idea of, like, okay, here's what her expectations were.
Yeah. So it was a while ago that I told you that story, and I have a lot of stories, so could you give me a little bit more information?
Oh, okay. I didn't know there's this whole catalog.
Yeah.
So the story goes that this trans person was in the waiting room, and another patient who was there at St. John's basically verbally accosted her.
Right.
Okay.
Yeah.
Is it good enough
So
to go on?
that story. Okay.
Yes, that one.
I can totally tell that story. So as he said, there was a patient that was there. It was one of our clinic days, and at St. John's, the trans clinic is housed in a community clinic in South Los Angeles. So we don't have like a special or different or unique location. Our clinics are just embedded into everyday clinics that are happening. And you have to remember, St. John's, we're quite large. We see up to 70,000 patients a year. And so so this patient was here, and she was waiting, and a gentleman in the waiting room started making comments, but in a passive way, so that it wasn't directly, like, wasn't making necessarily eye contact with her, but was making comments that was very clear that was about her and regarding her gender and referencing, like, calling her a freak, and then sort of escalated to he felt that it would be acceptable that he would physically assault her to sort of teach her a lesson, which again is sort of the world that we live in around how we feel about trans women and trans femininity is that there's a lesson that needs to be taught there, even as you were saying, like, how manly are you? There's a lot of gender policing and testing that's going on. And it escalated, and it came to the attention of some of the staff. And the staff, they were ill-prepared. We had done a lot of training, but the reality is that they were ill-prepared for something in the moment, a heated sort of argument in the moment. In typical situation, the person who was being abusive would be asked to leave and relocated probably to a different clinic location. But the trans woman said, look, I actually don't want you to do anything. I don't want a lot of attention because I have to walk to the bus, and the bus stop is like a block away, and I have to walk by myself, and if you kick him out of here, like, I might not make it to the bus. He might get me. He might beat me up. He might kill me. He might do something. And so it's fine. Just ignore it. Don't worry about it. Let it go. Please stop making such a big deal about it. And so, I mean, I think that that's such an indicator of, for her, she knew that there was a limited amount of things that we could do. We could say, you can't be here to the person who is assaulting her, but we can't protect her. We could walk her to the bus stop, but at some point she leaves us, and she knows that by calling attention to this, which she has the right to do, that she puts herself in increased risk, which is just beyond frustrating because it continues to that cycle of victim blaming and that sort of perpetuation of, so you're accosted by this gentleman in the waiting room, but the system is so unfair in the way that now you've been also victimized in the sense by us not doing anything. Right. And so it was a hard decision for us to make. Do we really respect what she's saying of, like, please don't do anything? And we really wanted to respect her, but on the other end of it, like, we actually can't allow violence, verbal or physical violence, to be happening it was a very difficult decision to make, and ultimately we decided to honor what she was asking of us because we felt like she was probably the best experts in how to keep herself safe, and so we respected that.
Did you have a separate waiting room for trans patients in the future?
We did. I think we had it prior to that, and we had it, after that. There was another place that folks could wait if they wanted to wait. And some people really liked it, and some people really didn't. I mean, I think that a waiting room in a community clinic, regardless, it's a little intense in those waiting rooms. There's a lot of people, there's a lot of noise. And so some of the patients were really quite interested in being in a different location. And some patients really felt like, I don't want to be someplace else. And so what we tried to do, and I think we did it okay. I think we could have done it better, but I think we did it okay of saying, let's give you options and wherever is best for you. But again, giving people options to be someplace else is not addressing the issue. It's putting a Band-Aid on a situation so it's figuring how do we address the problem, and the problem is not a separate place. The solution cannot be a separate place. And so that constant balance of like, I don't want you to be uncomfortable while you're here for your appointment, and how do we balance all of these things?
I also want to talk a little bit about how complicated the healthcare system is and how bureaucratic it is. I got a chance to talk with a guest on Take Two in the past before. Her name is Duran. She wrote this book, which should show up shortly. Her child, CJ, that's on the left, he is a gender non-conforming child, so what that means for those not in the know, he identifies as a male, born biologically a male, but just embraces things traditionally more accustomed for girls, pink things, girl toys, etc. I was asking her what her experience is like raising this kid. I think he's about 8 now. And she told me years ago when he was about 4 years old, she was looking for a family counselor, and she had this story to share.
So we talked to the pediatrician, and so she referred us to what is normal through our insurance is you go through an intake process where you go and you see an intake professional through the Department of Psychiatry. And they ask you some questions and learn about your history, and then they assign you to a therapist or a psychiatrist. And so they had us fill out all of the forms that they would have anyone fill out. It was hard because those forms weren't geared towards children. And then they got to one where when it has anything to do with sexuality and gender, they give you a form to fill out that has to do with sexual deviancy. Does the patient masturbate him or herself? Does the patient try to masturbate others or animals? I handed it back and I said, I'm not going to fill this out. And so my husband grabbed it from me and was like, well, let me see. And he read it and he was like, no, this isn't our son. This isn't for us. I didn't feel like something was wrong with him. That's not why I wanted him in therapy. It's not why we wanted to be in therapy. We just wanted to understand how to parent him better.
Dr. Baird, when I kind of mentioned the details of the story, you sort of mentioned that this just not might be an issue with a specific doctor's office. This is just how this is framed in the medical world. Talk a little bit more about that.
Right. So, this is all about, you're referring to the DSM?
Yes, that lovely thing.
So the DSM is this nice, do you have a picture of it?
The entire book,
this
hundreds and hundreds of pages.
Gigantic book that...
and that stands for, actually?
The Diagnostic Manual.
Yeah, but this is where I went crazy with PowerPoint because I discovered how to use it. DSM, it's also the Psych Bible.
It's the Psych Bible. So if you see somebody in mental health, they are, making a diagnosis based on something that is laid out in their Psych Bible, as we call it. And until the recent update of the DSM, it was considered to be, if you were transgender, you were considered to be, they didn't consider it to be necessarily something normal. They considered it deviant behavior.
Right, yeah, here's some of the language that I pulled from it.
It's not pleasant.
This is the DSM-IV. We're in the 5th version right now, but this is the one that came before it, gender identity disorder. If you want to read that all, but you can give us a summary.
Right. Yeah. This is, it's, it's kind of what we consider old thinking. I don't know that as somebody outside of the mental health world, we really saw it in this manner that there was something, wrong with someone.
But this is the guidebook that
this
professionals
is the guidebook
have to go off of.
And this is, if you look at guidelines even for endocrinology, if you look at our guidelines for hormone therapy, surgical guidelines, the first step is that somebody from mental health makes this diagnosis that you have gender identity disorder. And having a disorder is a kind of a poor term, and it's very, I think, a poor representation of really what's going on for people. And so with the updated one, they call it gender dysphoria, which, I'm not transgender, so I still think that would be an unpleasant way to define yourself or be defined by someone else. But I think it's an improvement in then calling somebody having a mental disorder.
By the way, and you told me a little bit about how coding comes into
Right.
all this too.
So coding is very difficult to have conversations when people come in. They don't want in their actual medical chart that they have gender dysphoria or that they're transgender. And we have a conversation about this. This is an insurance. This is the World Health Organization. They have mandated that you have to have a diagnosis. This is for, to get paid for reimbursement. This is for a whole bunch of other disease tracking. This is not something that physicians have literally any control over. We don't get any say in this. There's nothing that, when you come into my office, the first time you see me, you get that diagnosis from a mental health provider. And then from then on, I pretty much don't ever use that term. If you're getting testosterone, you're getting testosterone. That's it. That's all you're getting. And lots of people get testosterone, or you're getting estrogen therapy. And I don't think that anybody needs to have it thrown back in their face or on, paperwork or out for anybody else to see that you have any other diagnoses. But this is something that, a lot of times when my patients ask me to remove it from their chart or ask me to remove it from something, unfortunately, that's not possible because it's literally required for billing for all insurance companies.
And Aydin, tell us a little bit about more of that history, the fight over this terminology, changing it, et cetera.
Yeah, I mean, when we sort of look back at the standards of care and where this all began many, many, many years ago, because the standards of care have really informed and guided how we've come to understand gender identity disorder and now gender dysphoria. And I think that the movement to get gender identity disorder out was long fought. And there was a lot of advocates and a lot of people working very, very hard, justifiably, to get it out. But as Dr. Baird just said, that there has to be because of the world of insurance and the world of finances, there has to be some mechanism in place in order to bill for things. Do I think that there's a lot of other ways that as trans people we can get our medical needs met and providers can bill and get reimbursed? Absolutely. I definitely think that. I think gender dysphoria is a better description of what's happening for folks. Mm-hmm. The chronic and persistent discomforts, the dysphoria that accompanies for a lot, not all, but for a lot of folks who are trans, that is a much better descriptor, the experiences of.
And just so I'm very clear, dysphoria means what in medical terminology?
As a trans person and someone who unfortunately has to use the DSM to diagnose folks in order for them to get care and treatment, it's the chronic, persistent state of discomforts largely related to your secondary sex characteristics, those that are associated with whatever your assigned sex is, that are probably incongruent with your gender identity. And so gender dysphoria, the primary treatment is transition, if that's what somebody elects to do. And I think it's important to note that treatment helps gender dysphoria, certainly doesn't make it go away for everybody, and varying sorts of forms of interventions. For some folks, gender dysphoria is most and best alleviated through surgery. For some folks, it's hormones. For some folks, it's social transition. And for some folks, they don't experience a lot of gender dysphoria. Mm-hmm. And so I think that it's an important thing to think about, is that none of these things look a singular way, which is why it's so important that you have medical providers and doctors and clinics who understand that these are terms that are very one-dimensional terms, but gender is an onion, and it's complex and it's complicated. And so when we talk about providing trans care, we need to have providers who are willing to take that time and work through that onion. Mm-hmm. And understand of saying, like, I get that the medical model is like a 5-minute appointment. You can't do good care in 5 minutes. You can't do even mediocre trans care in 5 minutes, and so that's that advocacy piece of understanding how do we take all these pieces in the puzzle of the DSM and the diagnostic and the clinics and coding, and how do we create something that is a model of excellent, informed consent, celebratory care for trans people.
What does it stand right now, by the way, in the DSM? Is there work by trans advocates to change that, get it out there? What's happening?
Yeah, I think that there are going to be ongoing work groups to get gender identity out, because if you're not transgender, it means that your gender has never, ever, ever been pathologized, and you never actually had to go to a therapist. And there's all these sorts of things to think about that as trans people that we do, and it just sort of has become normalized and part of our narrative. And so yes, I think that there is a great group of people who are working to say we have to figure out how to do this differently. We need to have organized care. We need to have care that's standardized. We need to have these things because it's the right thing, and it's how you get good care. You know, you don't want willy-nilly care. Sometimes that's good, but sometimes that doesn't go so well, right? And so making sure that that's standardized is really, really important. But can we do it in a way that does not pathologize people's identities? And I think that that's the movement. That's where we need to go. And I don't have that answer, and I don't think those group of people have that answer, but we got to keep talking about it. And we got to make sure that trans people are at the table of these conversations.
And Dr. Baird, just to give us a little timeline here, the DSM changes how often? So when could the next update be?
I think the last one was 2002.
Yeah.
Okay.
And so then this one just came out. So, I mean, everybody can do the math on that one. The next one, they'll probably start meetings in the next year or two.
And these are just like psychiatrists who just get together and say like, hey.
It's not just psychiatrists.
Okay.
You know, there are not only psychiatrists, but there's social workers, therapists involved. And then everybody has some advocacy. So the Transgender Law Center has advocated for some changes, but there are other advocacy groups that have really tried to push for moving this away from being a disorder and more recognized as something that is, you know, it's hard to talk about a spectrum when almost all of us really see things, when we like to classify things as very binary. And the world is really not. And this is part of that. You know, not all of my patients who come in have some of them don't have any dysphoria. So I'm calling them a diagnosis that if you don't have dysphoria, I mean, what do you really meet that classification? Yes, they may not want hormones, or yes, they may have surgery, but, you know, they may be fine. If they never had those options, they may be fine completely with just living the way they are and presenting the way they are. So I think there's a lot of problems with labels, and they're necessary insurance-wise, and they're necessary for a variety of other, even for research. I try to tell my patients, like, look, I know this sounds really, not positive, but you're in some research projects probably in the future if you agree to them, because we're able to find you based on some diagnoses. And this is how we improve our systems. This is how we get people educated, is hearing you at panels. It's, changing the way, getting your feedback. We have multiple projects going on. We get, patient stakeholders involved so that they can give us feedback so that we can, change as this environment changes, because that's really what's probably the most important thing, and what, so we can keep moving that bar up, and not having that, just hitting the low-hanging things.
All right. I'll be turning the mic over to the audience shortly, but before we get to that, I had one last question, and it's about diversity. You mentioned you're a white guy, but of course the trans community is much more diverse. Caitlyn Jenner, also white, but there are many more people of color. And she's a Republican, which apparently everyone was very surprised by. That's what I learned. But as I've learned, there are some cultures who are more accepting of trans people than others. I got a chance to talk with Bambi Salcedo. She is from the Trans Latina Coalition. She couldn't be here tonight, unfortunately. But I'm glad I did talk with her beforehand, because one thing I took away is that just within her own community, it's a very different process.
Many parents who support their gender nonconforming kids are primarily of Anglo descent. And so they have resources. They have a way to refer to a therapist. They may have insurance. So it's easier to have access to different types of services. And again, my family didn't have the level of education. And that's the same for many Latino families too. They don't have the levels of education. Within Latino communities, it's obviously, the ignorance that exists.
Alex, I wanted to turn this over to you. This is something you mentioned as well.
With the diversity?
Yeah, in terms of being a minority transgender person.
I think within the African American community, a lot of the issues that we have kind of stem from maybe religious backgrounds, or just in the African American community alone is more like, men are men and women are women, and like for me, I didn't know what transgender was for a long time because I thought that only white people transition. Like black people don't do this, because I didn't see very many African American trans people that were transgender. So I was like, well, maybe black people don't do this. Maybe it's one of those things that white people do and we don't do it. So for a long time, I didn't know that there was a term for it, and I didn't see a lot of it within my own community.
And let's get to your community groups right now, which is really fascinating. The Brown Boy Project, the Frat, Alpha Omega Nu. Tell me a little bit more about the things you learned there and the support you found, and also what they are.
Okay, well, the Brown Boy Project is it's an organization that kind of raises leaders out of the people of color out of that particular community, and it raises advocates. It brings out different leaders in different aspects and different type of generations. Like there was a cohort that was specifically 18 and under, so they were bringing up leaders out of the youth specifically. And then the fraternity, we do a lot of advocacy work. We do a lot of community work.
And by frat, we're not talking like Revenge of the Nerds here.
No,
it's more like,
no, okay. No. It's a community-based organization, and we do a lot of work specifically within the LGBT community, as well as we have frat boy fun too.
Okay. How important was that for you in learning about trans people, finding resources?
Well, my first experience was with the Brown Boy Project. I actually was able to interact with other people of color that were transitioning. I said, oh my God, there's black people that do this. So I got a lot of being able to see myself in that reflection and say, okay, well, this is where I belong. I feel the same way they feel, and this is where I need to be. And in that, coming from a military background, a military family, I was always looking for like a brotherhood, always looking for like a family outside of my own family. And with the fraternity, I found a whole slew of brothers that were a lot like me. A lot of their ideals and thought process were just like mine. So with that, like, I feel like I've grown leaps and bounds just within the last 5 years being within these organizations.
Mm-hmm. And actually, Aydin, I mean, you formerly worked in South LA. It's a much different population than where we are right here in Hollywood. Tell me a little bit about, I guess, the difference in diversity depending on where you are in Los Angeles. What does it look like?
Oh, yeah, I mean, I think any of us could sort of think about where we maybe live and where we work and how different that really is. In South Los Angeles, we're a collection of community clinics, and so our goal and our objective is to be in communities that are marginalized and underserved and otherwise probably don't have great access or any access to healthcare at all. And so, I think Alex brings up a great point. Is that I think it's funny and yet it's completely true. It's like that you lived your life thinking like, wow, only white people do this, because there is an access thing, but. When we look at youth accessing care, through Children's Hospital, folks of color are accessing care post the age of 18. And so kids that are getting in early and getting on puberty blockers and giving that opportunity to halt a puberty that is inaccurate for them in early access to cross-sex hormones, the majority of those kids are white. Those are white kids who have private insurance, upper socioeconomic status, and so forth. So, I think that we can't pretend that economics and race and ethnicity and religion and background and all sorts of things don't play into the mix of all of these things when we start talking about it, because you can't pull any single part of this out for anybody. I think that in South LA, when we opened our clinic, we were like, okay, we're really gonna access folks in South LA. This is really who we're gonna provide services to. And instead, what we were providing services to were folks who live in West Hollywood, in Santa Monica, and Palm Springs, and San Diego, and Bakersfield, and Barstow, and San Bernardino, and Riverside. We were providing services to everyone who did not live in South Los Angeles.
And part of the reason they were drawn to you is because they didn't have resources themselves where they were located.
Right.
They had to travel to you.
Right. And, folks found out about us, or folks weren't happy with where they were at, or whatever it was. But I think that when we started getting patients from the South Los Angeles area, what people talked about was it never occurred to them that they could actually get services in their own backyard. Right? Because when services are hard to come by, you don't expect to find them in places it's unexpected. So folks who were in South Los Angeles and other areas were thinking like, oh, I'm going to have to go to the LGBT center outside of my community. And so people were quite surprised to find out. And so that demographic has changed.
Actually, Alex, was your mind blown when you found out it was so close to you?
Right. I was, because a lot, like, when I first started my hormones, I was going way out to, like, Alvarado on First. I had to travel like an hour out to just get to where I was going, because I didn't know that I had access that close. And so when I did find out, I said, oh, yeah, this is where I want to go.
Yeah, I remember a patient called and wanted to get scheduled, and they were like preparing to get all the directions and everything, and I gave them the address, and they thought I had sort of given them their address back because they were like, their house was like 4 or 5 houses away from where our clinic was. And I was like, no, that's our clinic address. And they're like, that's my address. And I was like, are we arguing right now? Like, what's happening? And then they realized that, the clinic had been there for, almost just under a year probably, and they had no idea. They thought it was just a medical clinic, and they had found out about us from a friend of a friend and Facebook and this, and it was like the telephone game. And so that was a remarkable moment of like, wow, this person's like 5 houses away, and they had no idea that we are here.
So for audience members, if you have questions, just head on over to the rows where one of our staff members with a microphone will bring it. Share a story, have a question, whatever. As you all migrate over that way, one extra question for Dr. Baird here. The Affordable Care Act. What changed the game for transgender people?
Well, I think the Affordable Care Act changed it for a lot of people, but specifically it provided protection against insurance companies whose previous practice had been dropping people if they had a pre-existing condition. And a lot of the insurance companies, they basically make their own rules about what a pre-existing condition could be. And if you were transitioning and you were a female to a male and that they considered that a pre-existing condition, that you were transgender, they could drop you. And so that was no longer, after the Affordable Care Act, that can no longer happen. They could also double the rates. So in premiums could be increased. So suddenly you go from $300 to $400 a month to all of a sudden they wanted to charge you $1,000, $2,000 for premium for the same basic coverage that you previously had. And it specifically calls out you should not be discriminated against for gender identity, which is a huge thing. It's California has that protection, but it is something very important in other parts, besides Los Angeles, which we all assume is a little more inclusive, but sometimes cannot be. But outside of areas, larger cities, that was really a huge change for everybody.
Right. So many people lined up. So let's start off with the left side. Sorry.
Does Kaiser cover surgery for transgenders? And the second quick question, do they cover voice therapy, speech therapy?
We do cover speech therapy. There are trained speech therapists in Southern California and in Northern California. Surgery, we cover in-plan mastectomy with chest reconstruction. They cover hysterectomy, oophorectomy, so removal of the uterus and ovaries, orchiectomy, which is removal of the testicles. Hopefully nobody's going to be freaked out by my medical terms. But and other surgeries, we have contracts with Dr. Crane and Dr. Toby Meltzer, who are outside excellent surgeons to provide phalloplasties and metoidoplasties, which, kind of is a game changer for the Kaiser members.
What don't they cover?
At this point, there's a lot of, I'm going to say negotiation with people who are much higher in their pay grade than I am about what often people will consider plastic surgery or reconstructive surgery, which is what Caitlyn Jenner had talked about, breast augmentation and facial feminization. those are very individual. They are, mostly trans women who are going to be seeking those services. And there's a lot of discussion about who is appropriate, not appropriate, how they're going to cover, who's going to do those surgeries. So that's kind of a work in progress. But the actual gender confirming surgeries are all available for Kaiser members and Kaiser employees also.
And you didn't mention it, but vulvoplasty and vaginoplasty for trans women are
Right,
included.
right. Sorry. The creation of a penis and the creation of a vagina.
Yeah.
Both covered.
I was going to Google
benefits.
this later because there was
Yes.
a lot of terms that just came
There was a
by
lot
that
of
not
terms. Those
familiar
are a
with.
lot of, we know as doctors we love our big words.
Let's go over to this side. Hi.
Hello, my name is Aaron Sines. Hi, Lou. And my question pertains to my day job, as I teach medical coding and insurance billing and all the wonderful medical terminology. And the question I had was more about the ICD part of it, and you kind of addressed it with the DSM part, but it also ties into the Affordable Care Act, where now we're actually practicing health care instead of sick care now.
Right.
And how is those two combining together to really change the language of what's happening in trans health?
Is that for me? Or is that for anybody? I mean, I'm just going to advocate
go
for
with you.
Kaiser because I'm a Kaiser
Yeah.
doctor. And, we've always done healthcare as far as I'm concerned because we do preventive care. If you've ever been to an appointment where you haven't had your flu shot, you're going to be bugged 50,000 times. If you need your colonoscopy, your mammogram, your pap smear, your pneumovax, whatever it is, that, Kaiser considers all of that regular routine healthcare. Changing billing codes and the DSM and all of that. I mean, we implemented this before the Affordable Care Act was put in place, before even the Department of Managed Healthcare came out with their quote-unquote policy non-discrimination change in 2013. I was already here and we were already working on this process and already had people in our system that we were setting up for surgery. So I think for us as Kaiser, it increased the number of patients. So like Aydin, we went from 23 patients when I first started almost 4 years now. We're now at 650. And that does not include the people we've already have transitioned through surgery. That is the active group of people just in Southern California who are in the process, have either signed up, who are looking to have top surgery and or have already had top or need bottom surgery, or who have already had part one of a bottom surgery and need two. So I don't know if for Kaiser that's really changed us personally, except that, as we move to ICD-10, the
And what does that
sky
stand
is
for, by the way?
falling.
That stands for the coding.
I'm sorry?
ICB stands for?
ICD-10, that's
ICD.
the coding that all insurance
Okay.
companies require. So if you leave your doctor and you have like hypertension and it's got a little number next to it, that's your ICD.
Okay.
That's how insurance companies get billed and paid.
This side.
Hi, my name's Dr. Anna Arrowsmith. I'm currently writing a book on gender, and I'm having difficulty finding an accurate figure of how many people of the community transition from a male body to a female body and vice versa. I've got a question. Do you know where I could find that out? Thank you. My second question, more importantly, is I keep hearing that it's much more the case, about 85%, that you have a male-bodied person transit, I'm using language plainly, into a female one. And if that is the case, do you have any thoughts, I think specifically Aydin and Alex, as to why that might be? Is it the truth? I keep hearing that.
I think that, it's interesting, I've asked this question a couple times. I've been doing some training in San Diego and a variety of different places, and this has been a question that's come up a lot. Is to think about where have those numbers come from? The statistics of like how many trans women are there compared to trans men, and largely those numbers are coming from folks who are accessing surgery. And so there's a lot of trans men throughout history and even present that we can negotiate and navigate our lives without participating, without having surgery. And so those numbers are going to be represented differently from that place. But I think that's something that the Affordable Care Act has changed, because in addition to everything that Dr. Baird said, is that it explicitly says in there that you have to cover. Not only can you not deny it, but you actually have to cover it. And so that's an additional statement that's really, really important. So with the Affordable Care Act, I think that we will potentially be able to get some numbers that more accurately reflect our community, because access has changed a little bit for some folks. Not everyone across the board, for sure. I think that anecdotally, I think that there is a pretty equal distribution of trans men and trans women. Trans women are access care differently, in different kinds of care than trans men do. Conversely, estrogens and feminizing hormones are easier to get your hands on outside of a pharmacy or a prescription pad than testosterones are. So masculinizing hormones are a little bit more difficult to get a hold of. And so, trans men, we have to access medical care in that regard in sometimes ways that trans women don't. And so thinking about where are these numbers coming from and what are the services that folks are going for that these numbers are being pulled for, I think really, really skews the numbers overall. The idea of how many, it's like the how many, until the census figures out a way to ask an incredibly complicated question that goes something like this. Does anyone in your household identify as transgender? We're actually gonna have no idea, right? Because the question, they're like, well, how do we ask it? It's like, well, it rolls out something kind of like that. And here's the thing, is if that household's like, what is that? Then the answer is no. Right? So I think that we need to think about how do we get better data other than people who are accessing surgery and accessing medical care. And what about all the folks who are going to Thailand to get surgery? Or what all the folks who are going to Canada to get surgery? Or surgeons who are like, I don't even know that this is called trans surgery because I'm just doing chest reconstruction for somebody and I'm not calling it that, so it's not being reported. So we have an issue with how we're getting our numbers.
Alex, what's your take?
The same as Aydin's.
Okay, that was easy.
I think, just the only other thing I have to say is I think it was maybe the Human Rights Campaign. They have a large study they were looking at. I'm going to just throw out a number. I think 6,000 people that they surveyed, specifically to look at numbers, male to female, female to male, agender, non-conforming, and the numbers were pretty even. And I think it's 2011 is the study. It's a non-discrimination, transgender non-discrimination or non-conforming. If you look on the Human Rights Campaign website, they have a large PDF. I think it's like 160 pages of really good data. Everything else that everybody else quotes is, like Aydin said, it's based on, if you look at the New England group who based all their numbers on transgender men and women were based on name change and sex change if they were getting your passport. So not everybody's going to do that, so that doesn't make a lot of, necessarily a lot of sense to use that number. But everything else, the biggest one is the Dutch study. Again, if most people access their care in the Dutch system. They're not looking to necessarily go to Thailand because they were way ahead of everybody else in what they were doing. But again, still the same thing. If you choose not to change your name and you're not choosing to access care or use, a surgical, access a surgical clinic in their clinics, then you don't know. But they do have the largest group of patients that they follow every single thing, whether it's hypertension. They know the diagnoses down to the last person in that country.
By the way, Aydin, when you're mentioning the ACA and how things might change, how long does that take for us to get some numbers that people are confident with?
Numbers as far as reporting numbers?
Right.
Well, what I was just going to say is, just collectively here, so you just referenced Kaiser has 600 plus, almost 700 patients. St. John's has just under 500 patients. Children's Hospital has just under 500 patients. I don't know if someone in the audience has any idea how many patients the LGBT Center has. Just demographically, if you look at the clinics that are here in Los Angeles, that's a large cohort of people. That's a large cohort of people, and it is absolutely not representational of the trans community at all. And we have to think about, again, working in South Los Angeles, there's a significant portion of our patient population who will never be counted because they don't have quote unquote legal status. And so we have to think about that being trans is not a white experience. Being trans is not a black experience. Being trans is not a Latino experience. It is an experience that crosses all sorts of spans and again, folks who don't have Medi-Cal because they can't get Medi-Cal, or they have My Health LA that has a lot of exclusions as far as what is and is not covered as it relates to being trans. We're in Los Angeles. There's a ton of folks who will never be counted simply because of that systemic barrier. I do want to add really quickly, there's a couple of things. The Injustice at Every Turn is the survey that has almost 7,000 respondents, and it's really great. You had asked a question about diversity in communities that are accepting or not. What they've done is you can extract data based on a variety of different things, and one of the things they did is, of the respondents, based on race and ethnicity, which groups tended to be most supportive of their trans and gender nonconforming family members. And so there's data in there, and it indicated of these respondents, it was Black and African American community tended to be the most supportive of their trans and gender nonconforming community. So when you ask that question, like, you can actually pull that specific data report from that large study. It's pretty cool.
This side.
Tons of paragraphs, tons of charts.
Yeah.
Hi, my name's Queen Victoria Ortega, and I've been a longtime activist here in Los Angeles, and I'm representing today the Royal Court, which is an organization that does advocacy in the trans community. My day job is working at St. John's in the transgender health programs. My question, which is two questions actually. The first one is regarding insurance. I think we touched on it briefly, but we're talking today about going beyond the spotlight, and we see what's going on at a national level of the tipping point. However, that does not speak to the vast reality of many people who are having these barriers. How is insurance a barrier? For example, what is available to people who are on Medi-Cal? The large majority of our community does not have the money to have private insurance. What are the options for them? For example, reimbursement for surgery or reimbursement. Why doesn't, for example, the mental health community take reimbursement from Medi-Cal? That's one question. The second question is, we also briefly touched, I happen to be a transgender Latina, and in fact, if we look at regionally, I'm not a minority. We're a very large majority of the trans community here in Los Angeles. But if you can touch on some of the barriers that you have encountered for transgender Latino community here, that's, for example, monolingual Spanish speaking or does not have adjusted status.
Which one of you all wants to address which one?
Yeah, so I think that so let's assume that you do have full Medi-Cal and you are elected one of the plans that are offered in Los Angeles. Certainly the barrier is finding providers, as you mentioned, who are willing to take the reimbursement rate that Medi-Cal offers. And Medi-Cal offers more often than not, a less than stellar reimbursement rates. And so providers are not overwhelmingly compelled to accept Medi-Cal for that reason. I think that the upside of that is that because we are in LA and because there is an awareness that there's a large community and there's a very large need, that there are surgeons who are now negotiating with a variety of different Medi-Cal plans, managed Medi-Cal plans, to get appropriate reimbursement rates. As a mental health provider, I can tell you what influences me and my colleagues to or not to accept Medi-Cal through reimbursement is the reimbursement rate. It just comes right down to the reimbursement rate is more often than not, sometimes half or a quarter of what our typical hourly rate would be. I think that what is really amazing and fantastic is I have the opportunity to remember what it's like to be on the other side of that chair, sort of going through this process. And so we have the opportunity to negotiate, and we're in negotiations right now at the Los Angeles Gender Center with some of the local insurance companies here in Los Angeles to become contracted so that we get a more appropriate reimbursement rate so that it increases access for folks who have Medi-Cal insurances. So what was Queen Victoria, what was your second question?
The second question was regarding the Latino monolingual Spanish-speaking community whose status might not be adjusted.
Yeah.
I think you touched on it briefly, but I really wanted to take the opportunity for the audience to really hear more of some of the barriers that you've seen personally in providing services, or any of you have seen in being able to access services.
Right, yeah, so if you are Latina and, I talk with Bambi Salcedo about this, if you are undocumented as well, where do you go? Do any of you have any idea of what are some of the options to you?
You go to county.
St. John's Well Child and Family Center.
Yeah, Harbor, county. The very first person I saw, even though they were incarcerated, literally the first month I was a fellow and I was at county hospital, they called me from the Ranch Raider Clinic and said, we have a patient here who needs their hormones adjusted. And it was a trans Latina, and didn't speak English but had no insurance and had access to care there. You know, I think that that's very difficult because it becomes very piecemeal in certain parts, because again, it comes even a smaller group of people in a smaller, you know, maybe they don't have access to the internet regularly. You know, there's a lot of other things. So they're not getting on Dr. Google and saying, hey, where do I find the best person who speaks Spanish, who's going to help me with my transition, my surgery, my hormone, who also takes Medi-Cal. I think that's a very huge access and barrier. Because if you don't happen to make your way to the right person at County Hospital or at St. John's or at Harbor, you may be sitting literally in the next office over from somebody who knows what to do, but if you don't know how to access, or you don't feel comfortable because you're worried something's going to happen if you go to get access to care, or if you have to wait 24, 48 hours in the emergency room because you're not urgent, I think that that's very, very, it marginalizes a really large group of people. And we saw quite a few when I was at the Roybal Clinic, which is in East Los Angeles.
This side?
Hi, I work for a private practice with a group of therapists who we specialize in the LGBT community. It's called the LA Therapy Network. And what we run 2 trans support groups that we've had for years. And the biggest issues that we're seeing, and by the way, we don't take insurance because it's so hard to deal with, you know, and serve that community and to deal with the insurance issue. So that's on the side. But my question is, the sensitivity training that's not out there for the providers, I mean, right. we're seeing that in our groups, and that's the biggest complaint. So what kind of sensitivity training protocols, you know, can we promote, or can we start pushing? Because we're trying to find additional therapists to help us, because you've thrown out the numbers. We're not able to manage this. It's like, it's just growing, and the demand is there, but the support is falling behind, and we need more training for these providers. And in that.
And actually, let me add on to that question too. The transgender community, I mean, if you take a look at the numbers, it's a small sliver of the population. So to be a devil's advocate here, how do you convince a doctor's office that might say, transgender issues are there, but we need a critical mass before we're going to take this seriously? We don't know if we have any transgender patients. Why do it now?
Haven't we reached critical mass already? Yeah. I mean, I think that that's my response. You know, there's no way you can talk about these numbers that we have. You know, I'm talking about Southern California. I mean, just the people that I see in my own personal clinic who may have already had surgery. I mean, the 660 people that we have right now, you know, that, as Aydin said, that number's not going to get smaller. Mm-hmm. And if you're looking at people who are potentially going through something that's life-altering, could be very, very, very traumatic for them, their family. I mean, who wouldn't be a better candidate for having support? And trying to get out the training, I think, is very difficult. You know, we had WPATH, who kind of set out the Bible for transgender health with their standards of care not that long ago, their updated one. We had the WPATH trainers come out 2 years ago for Kaiser Mental Health, and we've then, since then, we just did another training where we trained almost 200 mental health providers in Southern California. But again, it's having access to mental health providers who are interested, and we have tons of people who are signing up, but if their panels are already full, how do you get more people? But, you know, I think that the problem is that, like all of this, there's not enough mental health providers, even in Los Angeles. Mm-hmm. And I think that's probably some of the problem that we all see with this access and getting enough people in. And how do you schedule people for regular therapy if they need it? If they don't, that's great. But if they do, how do you get, if you are booked out for the next 3 months, how do you get people in regularly?
And by the way, I just want to recall that you told me that when you had to train people yourself, you didn't have too many guides to work off of. You had to pull some things. You grabbed the Genderbread person from, what is the site called? It's called metrosexual.com.
Metrosexual.com.
Which, that's still the word, metrosexual.
But They have a lot of different
Right.
programs.
So do you have any advice for her on just, I mean, are there certain websites that right now are out there that can be a start if she
I would
wants
say
to do a
maybe
creative
Aydin
program?
would be better at that one.
I'm chomping at the bit over here.
Yeah.
So there's a couple of things. Is that I really want to come back to your question of the devil's advocate. And I think that exercising caution when you sort of play the role of a devil's advocate when we have thousands of trans women being murdered across the country, across the world, all the time. We have young people who are dying by suicide in these neighborhoods all the time across the country. And so I think that we reached critical mass years ago. And it's not until it really impacts somebody's like in their own backyard do we start to have a different relationship with it. So I think that we need to re-examine what we mean by critical mass. But I think above and beyond that, I'm a social worker. I took certain oaths as a social worker. My wife is a doctor. She took certain oaths as a doctor. Why does this matter? Why should we be doing this? Because doing nothing is doing harm. That's why. Doing nothing is not a neutral position. So you have to, if you're saying, I'm not gonna do it, then you are saying, I'm gonna participate in harming you. And until we understand that and really like get that in our hearts and our souls, and if we're gonna wait for the critical mass, then that critical mass is never gonna hit upper white middle class America. It's not gonna hit, right? And so we have to understand like who has to be impacted for critical mass to be achieved. I get really frustrated with that because we're dying. Right. We are dying. But at our own hands, at the hands of other people, we are dying, and so we need to get really clear about that.
A few more questions. Let's go on this side. Hi.
Hey, actually, this is really good timing because just what you had said, Tisha, right now that we need more healthcare professionals that are devoting themselves to this field. I am an ABOC right now, and I'm studying to become an LCSW. So
what are these
everything
acronyms
that
mean?
Aydin
Sorry.
has been saying, I'm like lapping it up over here, like, yes, I want to hear more. Because this is specifically what I want to do. I don't just want to be a licensed clinical social worker. I want to focus on the trans community. I want to devote my life to this community. And when I'd heard the rates of suicide, it broke my heart. And as a healthcare professional, I couldn't agree with you more. If we allow ourselves to remain silent, we will die. We will be forgotten. We are giving up on our brothers and sisters. It is critical for me to reach out a hand and lift them up. So what I wanted to see were a couple of different things. First of all, I wanted to see if there was a resource when you had said, we need an army of advocates. I work in a practice. This group practice has been around for almost 30 years. And the people who are working within it have a huge amount of experience. I'm by far one of the most junior members of staff. And we have a trans man as a patient. One of the members of staff filled out all of his paperwork with his old information. And she sent me paperwork where I walked into the waiting room to call him on back, and I used his old name and walked up to his sister and felt like a total idiot when he turned to me and he said, actually, that's me. And I said, are you trans? And he said, yeah. And I said, would you excuse me? And I got to go back and tell her, what do you think you're doing right now? He had filled out all of the paperwork, letting us know, this is the name I prefer to be called. And we didn't even bother to look at that. And when I have a bunch of sweaty faces looking at me, and somebody just says, well, you're a drag queen, what are we supposed to do? What do we do in this situation? Why don't we start by asking the patient, what do you prefer to be called?
And Alex, that should be standardized.
Exactly.
And that should just be standardized across all clinics as, preferred name, preferred pronoun. It should just be basic data collection.
That isn't.
Yeah.
Yeah, and actually, Alex, this is a story that you had that for you, it was really important for you to be able to have a preferred name at St. John's, for example. Tell us a little bit more about what that was like for you. It's so simple, but
which clinic?
At St. John's.
For St. John's, yeah. When I first went to St. John's, like that was a standard question. So what's your preferred pronoun? What is your preferred name, preferred gender? Like just that as a simple act. It was like, okay, now I feel comfortable.
It's a game changer.
Right, now I can relax. Now I know that when I go that my quality of care is going to be a lot higher. Just that alone gives me a higher quality of care.
But how common is that in doctors' offices around Los Angeles?
Not very, not common in the doctors' offices I've been to.
Not common in the doctor's offices I've been to either.
So what's it take to get doctors' offices on board with just changing that form?
Yeah, I mean, we don't do forms, so I don't, we have
Yeah,
all
paper?
electronic.
Yeah.
We don't, it's been over 10 years, I think, since they had paper. So we don't really, it's not that we don't literally have some of these similar problems. If I think our biggest problem is that, the information that we get comes from employers. So if you're still listed with a different name from an employer, that's what gets downloaded literally into our database. But my staff has been trained, many of the staff members have been trained across Southern California. If you have somebody standing in front of you that, if it says Jane and they don't look like a Jane, then they have been instructed, they know, what is your preferred name? It's really as simple as that. I mean, I know that sounds very basic and, there's a whole bunch of other issues and problems, but if you walk in and you aren't presenting, or, if somebody says to you, well, sir, and you've already gendered that person, they're trying to be polite, but the training has been, how can I help you? And I know that sounds really, again, very silly and stupid and simple, but it's, sir, how can I help you? You're trying to be polite, but getting rid of that, trying to gender somebody before they've even opened their mouth. And that's just training. That's just getting people comfortable and moving away from some of that, kind of old, language.
This side? Hi.
Hi, good night. Good evening. My name is Christian Garcia. I'm the administrator at the Southern California Men's Medical Group, which is a private clinic. We have 6 providers, 2 mid-levels. And just as an FYI, the audience may not know, but we bill electronically. So if your name shows up as Sarah on your insurance card, I cannot use a different name. I have to go by that name or else I don't get paid. But my question is to you, the panel, how do I reach out to the community? Who do I contact? What directory, what resources can you provide me that say, where I can go to and say, I have a welcoming place where you can come and feel comfortable and be yourself and be respected and be treated with care, with dignity?
Really quick, sort of to speak to the first thing that you said, what we figured out very quickly at St. John's is that we bill all electronically. Like paperwork is this thing that people talk about. So what we do in all medical records and how we bill is we put people's preferred name in parentheses, and then there's across the board training that whatever name is in the parentheses is the name that you use, regardless of what is outside of that parentheses. And we've had for almost 2 years now, we've had no issues. We've had no red flags with billing. It's caused no issues or difficulties whatsoever. And so that's just a little thing to think about. That I think that there are creative ways to figure out how to make sure that we're still including people's preferred name and preferred pronoun in. I think that reaching out to organizations and communities that are doing this work, so the LGBT Center, Kaiser, St. John's, Los Angeles Gender Center, the other therapy group that was already referenced by somebody who spoke up a few minutes ago, the LA Therapy Group, I think is what it is. So to look at who's doing this work and saying like, hey person, I want you to know this is my name and we're doing this work. And so it's about becoming word of mouth that way. That I don't think it's about specific advertising. I think it's like sort of walking the pavement to a certain degree of going out and connecting to people who are doing this work and who are seeing clients. Because I know when I was at St. John's, I had patients from New York. I had patients all over the place who were like, I'm moving to LA in 6 or 7 months. I want to get scheduled. At the Los Angeles Gender Center, we get calls from all over the place about people who are looking for mental health care and mental therapy. And so in-house we have, like, oh, you're in Pasadena. We know this doctor in Pasadena. But the only way we know that is if that doctor in Pasadena calls us and tells us that they exist, right? And so making sure that you're connected to existing organizations. The other thing about the person who did ask about trainings and so forth is that the Los Angeles Gender Center, we have a whole slew of trainings that we're doing. We house them largely through Antioch University. But outside of that, myself, Dr. Olson, who is the medical director at Children's Hospital Los Angeles, and Susan Landon, who is the adolescent director at the Los Angeles Gender Center, we are going to be doing a collection of really comprehensive 2-day trainings throughout Southern California region that is going to spend 2 full days talking about medical care, the ins and outs of mental health care, and the ins and outs of advocacy and social work. It's going to be really, really comprehensive. And so I think that there are a collection of us that realize that we need to start helping each other and disseminating this information.
I want to be able to get to the last 2 people before we're kicked out of here. Sorry, yes?
No one's mentioned it, and it's a crucial one. GLAMA, the Gay and Lesbian Medical Association, like that no one's mentioned it the 4 or 5 times the directory seems to come up. So I have to put that out there.
Yeah.
The first place we went to. And then all of your insurances that you're contracted with, double checking the directory, you're able to flag yourself as LGBT friendly through Cross, Anthem does it, everyone does it. So cross check all of your insurances that you're, that's what we did. Went through all 400 providers Blue Cross had and looked for that. And then all of the trade paperwork, like we went through Blade to find Dr. Rodriguez, like, so in Long Beach. So what GLAMA is crucial. They need to increase the membership, and you're able to go on there and find a local LGBT friendly provider.
And WPATH also, making sure that we're looking at these large organizations and these large sort of, being a member of WPATH is great. So if you have that person, you know, I just came an email today of like, there's this kid or this adult in Louisiana, a population town of 2. Does anyone know of any medical providers? And somebody else sent an email through, you know, and like, so WPATH is a great place to resource share as well. So GLAMA as well. WPATH?
GLAMA.
GLAMA? Gay and Lesbian Medical Association.
Cool. On this side. Hi.
Hi, my name is Matt. I live in Santa Monica, and I am a white, gay, middle-class, cisgender male. And the only reason I bring that up is because I think that a lot of the progress and movement within the gay and lesbian community has been driven by a lot of people that look and have similar experiences to me, and a lot of the energy has been focused around issues of importance primarily to people who are like me. And I've really appreciated getting all of your perspectives on people who are part of the trans community and work heavily with the trans community. But I'm wondering, besides healthcare, what are some of the other issues that people within the LGBT community more broadly need to be paying attention to with the trans community? Besides just healthcare, what are some of the local, the regional, the national issues we should be contributing to?
Let's see if we can go down the line here. Aydin, do you want to start?
Actually, I think I'm going to bypass my turn. I'm actually going to let Alex answer that question.
Cool.
For me personally, I would say that we would need to address more safety issues. Just walking down the street half the time is deadly for a lot of us. And I mean, deadly might be a little more of a exaggeration, but still it's very unsafe. So safety issues besides the healthcare, a lot of family issues. We go through, just like coming out in the gay and lesbian world, for us coming out as trans, we tend to lose a lot of family, a lot of friends, a lot of our social network just kind of disappears. So within the gay and lesbian community as allies, just kind of be a little mindful that we lose a lot more than just our names and our genders. We lose almost our whole lives.
I mean, I think I could probably give you a whole list of things that need to be addressed. You know, domestic violence, housing, you name it, it can be an issue or a problem for transgender patients. As Alex talked about, you know, something simple as jobs and respecting the fact that your job search is going to be more difficult and that HR shouldn't be causing this many problems, but it can. You know, addiction, access to, what we find a lot of times is that a lot of our trans women, especially, they're underinsured, they are underemployed. They often move from job to job, so they get in and out of insurance coverages. And they don't necessarily have a good support network, as Alex was also talking about. So I think that literally, if you started at the front of the alphabet of things that people need to advocate for, it's all there, from addiction all the way to housing and employment, and and healthcare, and just is basic needs, not basic needs. It all needs to be addressed, and it's great to talk about Caitlyn Jenner, and she does have privilege, but the rest of my patients, they're struggling with some variation of that list.
Last question over there. Hi.
Thank you for that question.
Here, hold it. Hi, I'm Marianne Brown, and I'm a marriage and family therapist in Orange County, and I treat quite a few trans people more recently over the last year and a half, and I'm really hungry for other colleagues to refer to, and in particular physicians. And I can access Kaiser Network, but right now I don't have any of my clients that have Kaiser. And so I wanted to say to the person here who spoke about wanting to reach out, I'd love to get your card, and I'll give you mine. But I really just quite simply would like to know if there are even any clinics.
In Orange County specifically.
Yes, thank you.
Yeah, there's it's a clinic. I don't know if they call themselves a clinic, so I don't want to mislabel them necessarily, but there is a process in which trans care is being delivered in conjunction with the OC Center. They have an endocrinologist that is there. I know that it's quite cost prohibitive for some folks, and that we have some patients at St. John's who just couldn't negotiate the finances piece of it. So I think that exploring what the financial resources are, I think are going to be really important when you're accessing services anywhere, because each individual clinic or service provider, you always have to figure out how to fiscally sustain whatever it is that you're doing, right? Like, we wish that we could provide everything for free, but that's not real. We can't do that, right?
Thinking about, for instance, a young, very depressed person who has Cigna. And he got an appointment with an endocrinologist, but neither of us have any idea about this person.
Oh, in the sense that you didn't know anything about the reputation of this particular provider? Yeah, yes.
Correct. And I have
It's really hard to see you, sorry.
called Cigna, and they have no idea what I'm talking about.
Yeah.
It's just any resources, I'd be very grateful.
Afterward, I'm happy to give you my card. I think that it depends upon the age of the person that we're talking about and where are they looking and what are their insurance, like all of the factors that have to play into, where does somebody get referred to and what is it they're looking for and all that stuff. So I'm happy to, and I'm very lucky that my wife is the medical director at Children's Hospital Los Angeles, the youth clinic there. And so if I don't know, it's really amazing. She tends to know. And so I'm happy to, if I can't help you, then I'm happy to make sure that email happens, that you get the help that you need.
Right. I know that there's a lot more questions and resources that people will have. We will have some way to contact some of our people on staff or some of the resources that they can offer us, like first places to start. If you have any stories yourself or want to share anything, Ashley mentioned this at the very beginning. I'm going to do a hard plug on this because we use it a lot. The Public Insight Network. If you want to sign up for it, again, what it is basically you agreeing, saying, yes, whenever you have a story that deals with X, Y, Z, whether it's LGBT stuff, I don't know, you're an accountant, or I'm a surfer, anything that you want to share with us that you believe you're an expert in, this is a way for you to say, hey, put me down. And maybe someday, not tomorrow, maybe in a couple years. Actually, Michelle Evans, who you heard from earlier, this is somebody who I reached through that network. So, and that was actually started from a question that happened in 2013, and it eventually found her and got her story that way. So if you have something that you want to share, just make sure to go onto that website, kpcc.org/network. That's right, Ashley, right? Okay, cool. And just go ahead and put in your information, and one day, sometime sooner or later, we will reach out to you, and we will definitely use you. But once again, I really want to thank this entire panel, and also you, the audience, as well, too. I think a lot of these issues are something that may be familiar to some of you, new to others, and I'm just glad that we got a chance to talk about what it's like to be transgender in Los Angeles, in the world, in America, and more. So once again, thank you again to Dr. Tisha Baird, Kaiser Permanente, Alexander Fuller, Man Fraternity of Alpha Omega Nu, and Aydin Kennedy, Associate Clinical Social Worker. Thank you to all three of you.